the night, Associate Professor Bruce Campbell. Associate Professor Campbell is a consultant neurologist and the head of hyperacute stroke at the Melbourne Hospital, as well as the director of the Stroke Foundation. He was the co-principal investigator and medical coordinator of the groundbreaking ASCEND-IA trial of endovascular clot retrieval following standard thrombolysis in acute ischemic stroke. Please join me in welcoming Associate Professor Bruce Campbell.
Thanks very much, Josh. It's a great pleasure to talk to you all, and it's really great to see so much interest in forwarding through with neuroscience in the future. So I was asked to talk a bit about how I got to where I am at the moment. Obviously, I'm relatively early in my career compared to most of my colleagues here, and it was somewhat sobering to think I was asked to project into the future what's happening in 2050. Well, I'll be retired by then, so there you go. So what did I do? I started medicine thinking I wanted to be a research scientist, and I had some advice from mentors that perhaps rather than doing a science degree I should go into medicine. And that's not just a cynical thing about being free of the 5-year grant cycle. It's getting increasingly competitive, I must say. It was also about, as a clinician, hopefully you ask good questions because you're faced with patients who have problems every day. Hopefully that gives you the inspiration to ask the right questions with your science. So I was in one of the old course where you did a 3-year basic sciences, so it's a bit more similar to what you guys do now with a basic science and then coming into clinical for the final years. And then I decided to do the BMed Sci, which again was a sort of slightly expanded scholarly selective. And I didn't really know what I wanted to do. I had grand ideas of going down to Peter Mac and talking about cancer immunology, but I went up here and saw a bloke called Colin Masters, who's a leading expert in Alzheimer's, and within about 20 minutes of seeing him, he nailed down a project, and it sounded really interesting, and I didn't ever get to Peter Mac, so there's my history. It wasn't particularly well thought through. So I then continued on to clinical years, and I actually enjoyed that more than I thought I would. Rather than stick myself in the lab, I thought that I should continue on with clinical work. And then, you get to advanced training, and again, there's another decision point. You think you get out of school and you make this decision to be a doctor, and that's the end of the decision. But of course, it's not. And I had great difficulty with my decision making. Even 2 weeks before I had to nail down the choice, I was still torn between haematology and neurology. And my girlfriend at the time did a pro-con, which was quite helpful. Ended up saying you could have weird hair like this haematologist, or you could go and look at weird things in neurology. But I chose neurology rightly or wrongly, and you do a couple of general years. I started stroke in the 3rd year, and then did a PhD. And I think that's quite a good way. It's a bit late for some of you who've already done PhDs and other things, but it was quite useful for me to get in the clinical specialty and then do the PhD as the start of a sustainable research career rather than stopping and starting as you might have to if you've done it before. That's nice if you have that option. Synergies of clinical research, imaging, clinical work. One of the rationales when I started off with a PhD, we all go into a PhD thinking, I'd love to really change the world, but the reality is most PhDs don't change the world. Someone said a nice analogy that you look at the stars up in the sky and you want to put a new one up there as your PhD, but most of us just take one down, polish it a bit and put it back up. So my sort of backstop was that at least if the PhD came to nothing, I should be at least quite good at imaging, having looked at strokes, CTs and MRs all for 3 years. The alternative, of course, would be lab work, like I've done in my BMed Sci, and that's a very valid thing, and a lot of doctors do lab work. For me, I felt that the scientists who've done it all their life have a bit of an edge, and it wasn't going to be as easy to switch between clinical and lab work as it is between clinical research. I then went on to do postdoc. I've actually stayed in the one institution, which is a very unusual thing to do, and perhaps not to be generally encouraged, but it did give me some opportunities. Like the ASCEND-IA trial, for instance, which if I'd gone to America, no one would have let some Aussie do a randomised multi-centre trial. What do I do now? I do a mixture of public practice. I'm a full-time university employee, and I do a little bit of private practice. And I also do telemedicine. So we have a rural Victorian statewide service that covers everyone with telemedicine. So someone at the hour of the morning, wander around will give us a call and we'll look at the patient on a telemedicine link and look at their CT scan and decide what sort of treatment they should have. And as was mentioned, I have other roles with the Stroke Foundation, writing guidelines, and various other teaching things. So probably I will continue to do that mix, and that's really what I've tried to do, is set up a mixture of things that hopefully will keep it fresh and interesting for many years to come. And so what I'm going to talk about now is some of the things I've done in research, just to give you a flavour of what you can do, and then I'm going to have to do that horrible future gazing thing, which is Yogi Berra said, predictions are difficult, especially about the future. So anyway, CT perfusion. Before I start talking about stroke, hopefully you've all heard of the ischemic penumbra. It's that hibernating tissue that hasn't got enough blood supply to fire up action potentials, but it's got enough to keep the basic metabolism ticking over. So if you restore blood flow quickly, it will come back to life. If you block a middle cerebral artery, there are some territories that don't have collaterals, alternative supply. That dies rapidly. The rest of it, variably between different you and I, will have collateral supply. And so that tissue is going to be hibernating, and some of it's going to die. And over time, what happens is that hibernating tissue gets converted into permanently dead tissue. And that's what we're trying to prevent with rapid opening of the artery. So we can actually image that pathophysiology with advanced CT or MRI. Now, unfortunately, at the moment, MRI is not a reality in the emergency department. You have to go up to another floor of the hospital. It's full of people that are having their knee MR'd or something else, and they get a bit angry if you pull them out halfway through the scan for emergency. And as I sort of skipped over there, but you can imagine brain cells are dying every minute. 1.9 million neurons per minute is the sort of statistical average, if you like that kind of phrase. So we don't want to be waiting around for that knee person to get out of the MRI. And lots of people have contraindications to MRI. There's still pacemakers and stents and things that make it difficult to get someone in an MRI quickly. So what we use is CT. The radiation is not a huge issue. The contrast is not a huge issue. It's in every emergency department. And it looks like this. We give contrast, we repetitively scan through the brain. You can see where the contrast is getting and how much of it's getting there. And that tells us the area that's supplied by collaterals, which is delayed. So those of you can see this right hemisphere here is getting delayed blood flow, and there's not very much getting here. So we look at the delayed areas, the area of collaterals, that's potentially salvageable. That's what's contributing to the patient's deficit. So their hemiparesis, their inattention, their hemianopia is all this salvageable stuff. And the bit that's dead is where we haven't detected any blood flow at all. And if I was to do an MRI, it would match up pretty nicely with that area of pretty much no flow. And that, in this case, is probably just the facial group of this artery. So the patient has a massive benefit if you can get the artery open quickly and convert a stroke that will turn into this into just that. It also makes it a lot easier to diagnose stroke. Stroke, sometimes it's easy. The patient comes in, looking off to that side, can't move their left-hand side at all. There are lots of mimics, and this is an example of someone who's 23, so you shouldn't have a stroke at 23, should you? But of course you can. And about a third of patients are in their working years when they have a stroke, and some of them are very young. So you might pick that there's a hyperdense artery there indicating clot, but it's pretty tough. And doing a CTP showing this abnormal blood flow makes it a lot easier and gives you an idea of what you can achieve in the artery. So we found it very useful diagnostically. One of the early papers from my PhD was one of these three, which showed that putting a threshold around blood flow could actually give you a pretty good idea of what was permanently dead. And we went on and worked with some friends at Stanford who produced this stuff called RAPID software. And this is a fully automated, objective, standardised way to identify what's likely to be dead, what's likely to be salvageable using CT or MRI, and that's what we've utilised in all our trials. Now, there are other things you can do with imaging. I've had an interest in can we predict the bleeding that can occur after TPA, which is one of the big concerns, obviously. When you're treating stroke, you get bleeding into the area of stroke, can kill people. And I developed this thing called VLCDV, very low cerebral blood volume, which is really the area that's getting no blood supply that's detectable at all. And you can imagine if it's really that severely, intensely hyperperfused, damages the blood-brain barrier pretty quickly, and if you then reperfuse that, you'll have a high risk of hemorrhage. And then, we've got some papers out of that. It's a very interesting concept that explains the physiology, but as yet, it hasn't really obtained the kind of positive predictive value that you'd exclude someone from treatment. I'm still working on that. The Extend IA trial, Peter Mitchell and I did, there's Peter at the MCG, we got the water there. Basically was a clot busting that we did as standard, plus clot retrieval. And clot retrieval is going with an angiogram, people like Peter Mitchell and Rick Allen goes across the road to do this, and there's a little retrievable metal basket called a stent that you capture the clot and suck it out under medium pressure. So if you had a large vessel occlusion, you had our CT perfusion imaging showing there's a lot of brain to save. We didn't have any other clinical limits, so we didn't care about age or clinical severity. It was really all about, do they have salvage in the brain, do they have a target to pull the clot out? And you can see that pulling the clot out mechanically is much better at getting the artery open. So 24 hours, virtually everyone who had the clot removal procedure had it in the open artery and great blood flow, whereas the TPA was pretty average. So how did that translate into outcomes at 3 months? Well, I'm going to have to explain the Rankin scales here. This is good for your general knowledge. So Rankin scale, 0 is a normal person, 6 is a dead person, 5 is in a nursing home, 4 needs help with their dressing, showering, toileting, 3 needs help with their cooking, cleaning or finances, 2 is independent but might not be driving or playing golf anymore, and 1 is back to all their usual activities but might have a facial tweak or a slight slur or something like that. So obviously the good outcomes are down this left-hand end, the bad outcomes are down here. And you can see there's a shift when you add clot retrieval that dramatically improves the rate of independent outcome. The number needed to treat, which you should all be familiar with, is the inverse of the absolute risk reduction, yeah? Yes, seeing some nods, good. Was 3. So every 3 patients you treat, someone gets independent. That's pretty powerful. Compare that with heart attacks. When you do this kind of procedure, you have a number needed to treat of 29 to save a life. So it's a very powerful and therefore cost-effective solution for people with a major stroke. There are 5 trials, they all came out last year. It's not common that you get 5 randomised trials, all showing pretty much the same thing, all in the New England Journal in 1 year. And what we've done now is put them all together. So we did an individual patient meta-analysis of these trials. This result's not particularly surprising. You take 5 positive trials, you're going to have a very positive result with lots and lots of zeros in the p-value. But it was good for precision in the subgroup. So we're able to show that, whilst most of these patients got the standard clot dissolving therapy because they were eligible for it, there were a few that weren't eligible. And that might be because they had some sort of bleeding problem or they arrived a bit late for it. And we were able to show with this analysis that yes, putting all that data together, there's a definite benefit if you can't receive TPA. And we still should give TPA if you're eligible. This is just to show you that if you look a few hours afterwards, 7% will recanalize spontaneously. If you give TPA, that goes up to 37%. If you do a clot retrieval, it goes up to 77%. So TPA is not useless, and we still want to use it at the moment. We're going to do trials that we're using properly, but that's not clinical practice. This is an angiogram. You can fish a clot out of the internal carotid, the first part of the middle cerebral, maybe the second part, but not beyond that, because it gets too tortuous and the current range of devices are not really suitable to safely go there. So that's something that may change by 2050. I'd like to think that the devices will get better and the entire arterial tree will be fair game for the interventionist. What about age? This is an important clinical point for you just to keep in mind. What we've got on the y-axis is the amount of disability patients have, with 1 being an entirely normal person, 0 being a dead person. And you can see as you get older, whatever group you're in, your chance of being really independent drops. That's not surprising. It's the same with any medical condition. If you're older, you don't do as well on average. But what you can also see is that at every level of age, there is a treatment benefit which is roughly equal magnitude. So we do not discriminate on the basis of age. If people are independent at 95 and still mowing their lawn, they're just as eligible for clot retrieval as the 25-year-old. Clinical severity, likewise. I told you that severity relates to the hibernating brain, not just the dead brain, so you can imagine that it's not a particularly good predictor of how you'll go when you open the artery, and there you go. Patients with a very severe clinical picture won't do as well as those with a mild clinical picture, but they will do better with the treatment if you done. Time window, I mentioned 1.9 million neurons dying per minute, if you believe that kind of statistics. The Mr. Clean trial, which just basically took everyone with a blocked vessel, showed that after about 6 hours there wasn't a lot of benefit. But if you select people with the kind of imaging I was talking about that shows salvageable brain, there's no relationship with time whatsoever. So it really indicates that whilst we need to move as quickly as we possibly can for everyone when we get the opportunity, if someone does wake up with a stroke or they've been delayed several hours coming down from the country, there may still be some benefit. We're doing trials now really trying to push out the time window potentially to 24 hours. So there's a lot of trials in that space. I've done some sub-studies on CT diffusion. So we're using this rapid software to identify how much dead brain there is, because you would think the more dead brain you had, the less likely you were to do well. And so this is just to show you the baseline characteristics of the ones who had CT diffusion were the same as the overall cohort. And what happened as you get a larger core, so we cut off here at 70 mils, but some of the other trials let them sneak in a bit larger. You can see that if you've got TPA, the chance of having a good outcome over about 70 mils is pretty close to 0. So what happens if you add clot retrieval? Well, it shifts the line up a lot. And it's pretty powerful. So even at very large core volumes, you're getting benefits. And this is something that's really changing the way we think about treating these patients, is that whilst if you want to get a home run and the patient to go home in the next couple of days, sure, you want a small core. If you have a large core, you'll still do a lot better with clot retrieval than if you leave them alone. And so we're really trying to push the boundaries there. This is just, again, those Rankin bars showing you that even with very large amounts of dead tissue, there are still a few people who get independent. And if you're willing to accept that if you've had a really bad stroke, getting home that needing some help with meals or shopping or something is a good outcome, which I think it is for most people, then a third of the patients are getting to that level, even with big cores. So if you go back to numbers needed to treat, it actually doesn't change that much across the spectrum because there's such a low rate of good outcome in the big cores if you don't do the treatment. So it never gets above 10, number needed to treat for that moderately good outcome, still at home, 5, moderately better on the Rankin 3. So if you're interested in getting people better than what they would otherwise be, clot retrieval is a very powerful treatment. Don't need to be too intellectual about who gets it. And it doesn't seem to be unsafe. There weren't hemorrhages in this group. So to conclude from that, increasing core volume is independently associated with poor outcome. It's prognostic, but it's not something that we should be excluding people from treatment because of the volume. So we've also done a general anaesthesia. Who knows about general anaesthesia? Is it good for the brain or not? There's lots of studies in rats that show it's protective against neuronal injury. In humans, not so sure. Unfortunately, we can cure rat stroke in about 1,000 different ways, and none of them are translated to humans, which is disappointing. But basically what we showed is that if you treat people with clot retrieval under general anaesthesia, you still get a benefit versus the standard treatment, but it's nowhere near as good as if you treat them awake. And so even though it's a bit uncomfortable, we should try to keep our patients awake for treatment. So here's the future gazing bit. I went to the 1950s to look forward. I think Chris is going to do a better job of this later on looking at history. But basically I think we will have miniaturised diagnostics, whether that's blood biomarkers or whether it's miniaturised imaging. I think we'll have treatment in the field. We will have better ways to open arteries. I think that our thrombolytics will get better. There's just simple things you can do in genetically modifying TPA, which will make it a bit more effective. I think there are things like nanoparticles which are being tried now and are helping, and improved endovascular devices. Neuroprotection I haven't talked about, other than saying that there are 1,000 ways to cure rat stroke that haven't translated. So one of the problems with all the neuroprotective trials to date is that there hasn't been consistently good opening of the artery. And as people say, you can't hold your breath forever, and if you don't open the artery, no matter how good your neuroprotective is, it won't keep the brain alive forever if you don't restore blood flow at some stage. So hopefully with reperfusion will come a renaissance of neuroprotection. There's a few trials coming through now. And restorative therapies, we'll talk about stem cells, we'll talk about other restorative therapies. They've got a long way to go. This is something that's not too far on the horizon because it's happening right now and it'll happen in Melbourne next year, which is the mobile stroke treatment unit. So I mentioned taking the treatment to the patient, and basically you can put a CT scanner in an ambulance and you can certainly deliver TPA faster and to more patients and identify people suitable for the endovascular treatments. So we'll have a CT in an ambulance in Melbourne next year. We'll be able to diagnose hemorrhage versus ischemic stroke. We'll be able to identify large vessel occlusion, and hopefully we'll be able to access that first 60 minutes after stroke onset, which has really been out of bounds just because of the time it takes for people to activate an ambulance and get to the emergency department and get treated. And the sort of tantalising hints that we've got are that thrombolytic therapy is probably a lot more effective in that time frame. Clearly there's a lot more brain to save. So it's a very exciting time. I have a fantastic team across the road. That's my email address if you have any questions beyond what can be asked tonight. So they'll disappear after the Q&A. But thank you for your attention.
Thank you very much for that, Associate Professor Campbell. Now let's open the floor up to a few questions from the audience, if there are any. Any questions for Associate Professor Campbell? Yeah.
I have a question. Yes, you mentioned that with the moment of launching the idea of getting ambulances with a CT scan to patients, so you can give kind of potentially the idea of blocking the risk of getting to get straight away. I'm just kind of curious as to, do you think, is that something that can be done by actual emergency ambulance people, or would you kind of say that you have the doctors actually come to the patient, diagnose them and treat them?
So ambulance guys do it for STEMI, for heart attacks, but that's based on an ECG, which is a little less complicated. So we do still at this stage need a CT scan of the brain to exclude bleeding, and so because of that we need to have a doctor involved. Now it may be by telemedicine. What we're hoping is that people like me will be on the ambulance for the first few months, and then we'll step back and use telemedicine to assess the patients. So we'll need the radiographer to apply the scan, we'll need paramedics, we'll need someone to keep the drug, but if we can transmit the images nicely by telemedicine, that will be sufficient.
Sorry, we'll skip again. So you said that there was a risk when you refused the area of hemorrhage. At what point do you decide the risk of hemorrhage is too great versus benefit of risk?
Yeah, so the non-intellectual way is to say the stroke's been going longer than 4.5 hours on the TPA, because on average the benefit drops off over that time. And it's not purely because the risk of hemorrhage is going up. It's a bit more complicated than that. But basically, as time passes, the clot is harder to dissolve, so TPA is less effective at doing what it's supposed to do. The risk of treatment does go up a little bit, but it's also the brain dying over that time. So it's really those three factors conspire to take away the overall benefit on average. But of course there are a lot of individual differences, and that's where that imaging I've shown you really tells you what you're dealing with in the individual. Is this someone with good collaterals that's got actually salvageable brain out well into the 8 to 12 hour period, or is it someone who unfortunately is killed in the brain tissue, they're going to kill in that first hour or two? Imaging is really the key, I think, to triaging the benefit versus risk, and what we're really trying to do in our trials is push the time window out of the equation and look at physiology. Yeah. Absolutely. So yes, it's preventive treatment is not very sexy, unfortunately. It's all don't get fat, don't smoke, eat well, and watch your blood pressure and make sure you don't go into atrial fibrillation. So that's all the usual cardiovascular stuff. Sorry? Say again?
Without increasing time window, combine using
So basically, preconditioning is one of the concepts that people have used, and you can use per-conditioning at the time of the event. So people are looking at whether inflating blood pressure cuffs and doing things like that might alter people's ischemic tolerance. And haven't come to anything yet, but it's an area of active investigation.
Dr. Campbell, just in relation to the neuroprotective mechanisms you're mentioning, has there been much research into, say, using NMDA receptor antagonists with clot retrieval?
Not with clot retrieval. So basically, you can think of a mechanism. There's been a trial about it. They looked at magnesium and NMDA and glutamate in other ways. The resurgence, the main compound I'm interested in, other than hypothermia, which of course is the one that targets most of those pathways, is a thing called NA1, which was developed in Canada. It's a PSD95 inhibitor, so it's acting on the glutamate pathways, and it has in primates made a big difference. So a lot of the problems were they were done in rats in one species in one context, and it didn't translate to other species. So at least this one translated from rats to primates. In humans who are having an angiogram, guys who do angiograms don't like talking about this, but it's quite common to flick off a little bit of crud and you get a tiny little DWI lesion after an angiogram just for diagnostic purposes. And this compound reduced the number of DWI spots. And now they've gone into a trial both in the ambulance and also in clot retrieval patients. And we'll see how it pans out. As my boss said, the enthusiasm for neuroprotection is inversely proportional to age. So I'm still in the enthusiastic camp at the moment, but I'll probably fade out soon.
We might leave it there.
All right. Thanks very much.
I'd like to invite you to begin to go along. It's for you. Thank you very much.